I've heard many people say that pharmacists are really overeducated. So we really have a lot of knowledge, but if we're just dispensing medicines and checking, we don't really get a chance to use all of that all the time.
I would say the industry is very segregated. Like if you're in the hospital pharmacy versus the retail pharmacy, you don't really communicate a lot.
Well, I think the costs are, you know, they're out of control right now, and healthcare itself, you know, there's a shortage of healthcare professionals. So I think that the care the patients are getting isn't quite up to par. So some people can't find a primary care physician to go to regularly. So I think that's why a lot of the times they show up at the ER or the hospital, because they don't have a primary care doctor to go to see when they're sick.
There is, and this is well acknowledged by research from the University of Hawaii School of Medicine, that there's a huge deficit in providers, which means physicians, nurse practitioners, physician assistants. There's just not enough to go around. So there's this huge deficit in people to do the work at the same time as the population is going out. And hey, we have this new school of pharmacy in Hilo putting out a lot of new pharmacists every year, and they are trained well beyond the ability to simply push buttons and watch machines twirl around and spit out pills and put them in bottles and give them to patients. What pharm2pharm is to do is to identify those patients who have complex diseases or multiple medications, to have them seen by the hospital pharmacist who works for pharm2pharm, who goes through some of those issues with them. Then that hospital pharmacist hands them off, signs them over to a community pharmacist who will follow them for a year. And the whole aim is to see if we can have those people get better control of their medications, better control of their illnesses, so they don't end up coming back in the hospital.
Hi, this is Kira calling from the hospital. I'm the pharmacist that you spoke to.
Well, from the get-go, we screen patients that are admitted. We look at their med rec, what medications they're on, if they're high-risk medications, if they're on a lot of medications. That's part of the treasure hunt, is finding out what went wrong with their medications at home to where they're sick enough to where they're admitted to the hospital. So after we figure that out, we talk to the patients, their caregivers, and then we offer to have a pharmacist work with them one-on-one to help manage all their medications. And then once the patient's discharged, within 24 hours, we now do the post-discharge phone call, which is where we remind them that, you know, they have an appointment with their community consulting pharmacist. We reinforce what medications they're supposed to be on, which ones are not supposed to be on. If they got new prescriptions, we're able to pick them up. Anything that we find with that, then we communicate that to the community consulting pharmacist.
Hello, Kira. Within, you know, a couple days, I would then try to reach you and set up a time to meet with you and, you know, just have a one-on-one, face-to-face to just kind of go into detail one by one over all of the medications.
Welcome, welcome, come in, come in, come in.
What we're seeing is a lot of people get readmitted so fast, even, you know, after leaving the hospital, and that's kind of where a lot of mistakes and problems with medications occur, is right after when they go home. And so, you know, if anything, I try to double check everything over the phone when we call the first time, but it's still, I think it's better to see in person.
Have you started it already?
No.
You haven't started it?
I'm short of breath right now.
You're not short of breath? Oh, okay. Well,
They use a spray whenever you're...
yeah, you're only going to use it when you need it.
I mean, I think that's the biggest thing, not even necessarily us focusing on trying to change drugs or, you know, getting things to fit the way we want it to be, but just educating the patients.
2. She seems to be very knowledgeable, and so do the students that come with her, because I mentioned the medicine, and right away they know what it is, and they talk about it, and you can tell me what it's used for and what the side effects are going to be, you know. So I find it very knowledgeable and very helpful.
You know, just being able to like go to people's homes and like, you know, you just see them like in their natural state, and you just kind of feel like you can relate more. You know, I think when patients have more support and care, and, you know, especially family, you definitely see the difference.
Thank you for coming, sweetie.
Thank you.
Appreciate it.
Call me if you need.
We have several instances where, very honestly, a life has probably been saved because the pharmacist intervened and connected the patient with the physician and the care they needed in a timely manner.
And you have a very good doctor
So my hope is that this will be recognized by Medicare as a useful project that has had good results, and that they will decide to make it a part of Medicare nationally.
Thank you so much, Martha. I really appreciate all the help you